I'm Dr. Ken Landau. Thanks for watching. Let's talk about urinary tract infections. They're going to occur this year in 10 to 14 million people. And as a matter of fact, 85% of those individuals are going to be women, typically between the ages of 15 and 30. And the risk of a urinary tract infection in that age group, 1 woman in 8 will develop a urinary tract infection during those years, so that by age 32, more than half of all women have had infections of the urethra, the tube that goes from the outside to the bladder. We call that urethritis. That's the urethra. Or infection of the bladder itself, we call that cystitis. Or sometimes infection of the kidney, we call that pyelonephritis. Pyelonephritis, much less common than cystitis. Pyelonephritis, for every 1 case, there are about 30 cases of infection of the bladder, cystitis. Now, infections are more than just the presence of bacteria in the urine. We know that actually asymptomatic bacteriuria, bacteria without any kind of symptoms, extremely common, especially in the elderly population, and oftentimes in women who are pregnant. Well, if you're elderly, you probably don't need treatment. If you're pregnant, you probably do need treatment. So a little complicated. But acute, uncomplicated cystitis, when you have normal structure, normal function, you don't have any cysts or anything else, well, the tendency is for the condition to be extraordinarily common in both premenopausal women and pregnant women, less common in postmenopausal women. In men, when they occur, tends to be over age 50. When people are diabetic, we have to be a little bit more concerned, especially if the diabetes is complicated because of the lack of ability to fight the infection. Or sometimes we talk about complicated urinary tract infections. For instance, when there's a stone or a cyst or some other abnormality in the urinary tract, or you can't empty out the bladder completely. Well, additionally, people who have indwelling catheters, those people are at high risk for urinary tract infections. And additionally, when we look at people who have bacteria in the bloodstream and have a condition we call sepsis, very serious medical condition, it often arises from that catheter. Now, 50 to 70% of sexually active women are going to have at least 1 urinary tract infection, and if you get 1, chances are about 25 to 35% you're going to get a second, and if you have a second, you have a fairly good chance of getting a 3rd infection. Actually, 2 to 3 infections are not uncommon, and some poor women have at least 6 infections every single year. Now, the infections are more common in sexually active individuals, and as a result, in postmenopausal women, the frequency of urinary tract infections is much less. It's much reduced. Now, the presence of bacteria in the urinary tract is not sufficient to make a diagnosis of an infection. You have to have the body's reaction to those bacteria. So you have to have some symptoms or some white blood cells or some red blood cells or something that suggests that the body is reacting to those bacteria. Now, sometimes women get frequent infections and they can occur very soon after treatment. So the question is that a relapse or is that a reinfection? Well, when we evaluate the kind of bacteria, somewhere between 50 and 90% of the time when women get urinary tract infections, it's exactly the same bacteria. It's not even a relative of it is the same bacteria. So the question is, where do the bacteria come from? Are you being reinfected? Typically, we think it's from a rectal reserve where the bacteria are in the rectum, and they can be transmitted oftentimes during sexual activities, or much more likely, are those bacteria still somehow in the urinary tract? And we can get those same bacteria even after we've had negative cultures. After your first attack, you can have negative culture, negative culture, negative culture, and then 6 months later, you can have a reinfection with the same kind of bacteria. And the same kind of bacteria is an E. coli, Escherichia coli. That's a common bacteria. That's the same kind of bacteria that causes Montezuma's revenge. Well, depending on the genetics of the bacteria, they have certain areas they like to grow in. And we have what's known as a uropathogenic type of E. coli that likes to grow in the urinary tract, that likes to attack the cells of, most of the time, the bladder, some of the time, the cells of the kidney. Well, in 75 to 85% of the infections, the E. coli is the culprit. And it gains entrance for the first time from, we think, the rectal reservoir and sometimes from the vagina. Now, it doesn't have to be E. coli. 15 to 20% of the time, it's going to be a different kind of an organism, Klebsiella or staph or strep or some enterococcus, and there are some other kind of unusual organisms. But those kind of organisms are much more likely if you have a catheter or if you have a stone. What are the symptoms of urinary tract infection? Well, the three big symptoms are either burning pain, dysuria, when you go to the restroom, it hurts, or you have to go right now, you can't wait, we call that urgency, or frequency, you keep going, but you only pass relatively small quantities. If you have one of those symptoms, you only have about a 50% chance of having a urinary tract infection. Even if it's dysuria, you might have urethritis, you might have vaginitis, you might have a sexually transmitted disease, but if you have two or more symptoms, then you have probably about a 90% chance. Now, on the other hand, when we talk about pyelonephritis, pyelonephritis can have either the same symptoms as cystitis or more likely a fever of more than 100, maybe some chills, some crampy pain, maybe some tenderness on your flank or in the area where your ribs meet the spine, sometimes some nausea, sometimes some vomiting. In children, in neonates, in infants, the symptoms might be just vomiting or fever or poor feeding or failure to thrive or loin pain. In pregnant women, we have a different kind of an issue because even when the bacteria are present without causing any kind of symptom, they might have some sort of negative impact on the pregnancy, cause a person to have perinatal mortality or low birth weight or preterm delivery or increased incidence of pyelonephritis, and as a result, any woman who's pregnant who sees her obstetrician probably ought to get urine culture. So it's one of the groups where we do recommend a culture, and we recommend a reculture to make sure the bacteria have gone away. Now, a dipstick examination, where one of those little pieces of coated paper are put into the urine and different kind of things are measured, probably not adequate. Well, in pregnancy, we have asymptomatic bacteriuria, just the presence of bacteria in anywhere between 4 and 7% of all pregnancies. In other words, one woman in every 14 to 25 going to have this kind of issue. And as a matter of fact, this issue, the asymptomatic presence of bacteria in the urine, can lead to pyelonephritis. And as a matter of fact, pyelonephritis can occur in a significant number, probably about 2% of all pregnant women, and that's the most common non-obstetric cause of hospitalization during pregnancy. Women who are pregnant require special kind of therapy. For the most part, the therapy is the same, but as we get closer to term, especially if you have a strep, a group B strep, well, that increases the risk of infection both for the child and for the mother, so special kind of therapy is necessary. And in elderly individuals, the symptoms might just be the new onset of incontinence or worsening of fevers or confusion, change in mental state or delirium or malaise or lethargy, maybe just pelvic discomfort. And the problem is compounded in older individuals because they might have other kind of issues, diabetes, disturbed metabolism, or dehydration. So you always have to be especially concerned. And in men, most men who have infections of the urinary tract actually have a urethritis or a prostatitis or epididymitis. They all have similar kind of symptoms, but those conditions, more frequently associated with sexual activities, are more common in younger men. The true urinary tract infections are more common in older men over age 50, or men who have kidney stones or diabetes or benign enlargement of the prostate. One of the most common causes of urinary tract infections in men, and the benign enlargement of the prostate might prevent the bladder from emptying more completely. In homosexual men, there's an increase because of the contamination with fecal bacteria, or in men who have catheters or some other kind of abnormality of the urinary tract. So a general rule of thumb is less than age 50, probably a sexually transmitted disease if it's otherwise healthy individual. Over age 50, more often going to be a urinary tract infection. Predisposing factors, well, the genetics. So your genetics and the genetics of the bacteria that you happen to get, they determine whether you are going to develop a urinary tract infection. If you have a family history, especially if your mother had a urinary tract infection, especially if it was relatively early in age, chances are you're at higher risk. Women are at higher risk because the urethra is much shorter than it is in men. The distance between the urethra and the anus, obviously, is much shorter. We have the permissive environment where the area around the opening of the urethra is moist and it's warm, and sexual activities can push the bacteria into the bladder. Well, women are at risk if they have new sexual partners, multiple sexual activities during the course of any given time. So if a person has sexual activities 3 times a week, that person's probably going to be 3 times as likely to have a urinary tract infection. And spermicides seem to be especially dangerous because they might kill some of the lactobacilli. And if you're incontinent, or if you have diabetes, or if you can't empty your bladder out completely, well, that can increase the risk. And obese women seem to be at greater risk. And so, too, are women who have stones or stents in the urinary tract, keeping the ureter open, or people with catheters, or people with benign enlargement of the prostate, people who have any kind of instrumentation. When you see the urologist and he or she sticks something into your bladder, you're at greater risk. People with spinal cord, people who are pregnant, at greater risk. Now, people have long said that women who use hot tubs or douches or deodorant sprays, or women who use tampons or nylon undergarments or dirty undergarments, people who've had inadequate fluid intake, or if you wipe from the back to the front, that you're at increased risk. But science doesn't really substantiate any of those ideas. And then some people think that if you urinate immediately after sex, or wash yourself immediately after sex, that's going to reduce the risk. I tell you, there isn't really any medical evidence that any of those things are true. Now, just because you have the symptoms doesn't necessarily mean you have a urinary tract infection. You might have, as we mentioned, a sexually transmitted disease, or vaginitis, might have urethritis, might have a kidney stone or appendicitis, or might have a tumor in your bladder, or maybe you have diverticulitis. Maybe you just have overactive bladder. How do we make the diagnosis? Well, the diagnosis is typically made on symptoms, but sometimes we have to consider, does the person have vaginal discharge? If you have vaginal discharge, the higher incidence that you have vaginitis or sexually transmitted disease. So if you have symptoms and you happen to be a college kid, well, chances are it's going to be a urinary tract infection. But if we're talking about somebody seeing the emergency room physicians on a Saturday night in a big city who has a vaginal discharge, chances are it's going to be a sexually transmitted disease. So the symptoms alone are quite sufficient to make the diagnosis, depending on the circumstances. Sometimes we need to evaluate a urinalysis, clean yourself, urinate into the bowl, then catch the second portion. We call that a clean catch urine. Sometimes, depending on the situation, a catheter is necessary. But the people who have catheters that are implanted and of long-standing duration can't use them. Now, typically when the urine is infected, if we hold it up to the light, it's not clear. So a clear urine is a good sign you don't have a urinary tract infection, except it all depends on the observer's vision. So we can look at it under the microscope, and we can see that there are white blood cells. Well, white blood cells are usually a sign of, or typically a sign of infection, but you can sometimes have white blood cells without bacteria. Sometimes you can have bacteria without white cells. So it can get a little bit confusing. And it also is important to consider whether it was really a clean catch urine, because sometimes if you don't take appropriate precautions, you can have a lot of contaminants in the urine. The dipstick, that little piece of impregnated paper that you put into the urine, that can give us some indication, but it's not very good indication. We measure something called leukocyte esterase. That's an enzyme released by the white blood cells, and if it's present, there's maybe a 60 or 70% chance that there might be an infection. And sometimes we measure the nitrites. They come from the nitrates that you consume in your diet, and they're broken down by the bacteria in the urine, but you have to have a special kind of bacteria, and the urine has to be present in the bladder for long enough. So the likelihood of nitrites signaling an infection is only about 50%. Well, if we have all of the symptoms and we have a positive dipstick, that's okay. So you probably have a urinary tract infection. But the symptoms alone are going to give us the diagnosis in 95% of the time. And the dipstick, well, it's going to miss about 20% or more of infections. So the dipsticks aren't good enough by themselves. Now, how about a culture of the urine? Well, if you're going to get the culture, you have to do that clean catch that I spoke about a moment ago. You have to get the urine to the laboratory within a period of 4 hours, because remember, the bacteria are going to grow, and if you can't get it to the laboratory, you have to put it in the refrigerator, or you could have a special container that has some boric acid. Now, there's a lot of confusion about what a culture means. Typically, it's thought that a culture has to show at least 100,000 bacteria in every milliliter of urine. In other words, in a milliliter. So that's 1/5 of a teaspoon. We have to have at least 100,000 bacteria. But the problem is that we've known ever since the 1980s that you could have a urinary tract infection with just 100 bacteria. And as a matter of fact, up to half of all urinary tract infections have anywhere between 100 and 10,000 bacteria. And why is this such a big deal? Well, it's a big deal because when you go to the laboratory and you give them a urine sample, if you don't have at least 10,000 bacteria, the culture is going to be read as negative. So you could still have an infection, but the laboratory says you don't have an infection. And as a matter of fact, that leads to a lot of people going back to the doctor again and again. Hey, I got the symptoms. I think I have a urinary... No, you don't have a urinary tract infection. The culture is negative. And then you're labeled as either having urethritis, or maybe it said that you have some psychiatric problem. But remember, most laboratories read as negative anything up to at least 10,000, or some laboratories 100,000 bacteria per milliliter. So you could have a whopping infection, but the culture might come back negative. Now, we shouldn't culture everybody who has a urinary tract infection, but we should culture men, we should culture pregnant women, we should culture people who've had a round of antibiotic, and then pretty soon they relapse, because those people are more likely to have a resistant organism. And certainly if you have diabetes, and the diabetes has some complications, then probably better get a urine culture. Now, if you have a repeated negative culture and you still have the symptoms, it is possible you have other kinds of disease. You could have bladder cancer, you could have interstitial cystitis. Well, one of the things that we also have to realize is, even if we're very sensitive about the number of bacteria that are present in the urine, and let's say the symptoms suggest urinary tract infection, 80% of the time the culture is going to be positive. But if we do really fancy tests on the urine, if we do something known as quantitative polymerase chain reaction studies, we're going to find that those bacteria are present almost 100% of the time. Now, we have an issue. If you have the bacteria and you don't have any kind of symptoms, especially common in the elderly, well, you don't need any kind of treatment. But unfortunately, if we do the culture and we find a lot of bacteria, those people are often given treatment, but the treatment might actually cause harm. It can cause harm because the bacteria are supposed to be there. They're going to come back as soon as the treatment is over, and the antibiotics are going to lead to overgrowth of bacteria in other areas, going to kill off the good bacteria, so to speak, let the bad bacteria grow. And we know that the presence of bacteria without any kind of symptoms in elderly individuals who don't have anything else wrong is not associated with hypertension or kidney disease. It has nothing to do with the likelihood of death. Now, in men who are about to have some sort of urinary procedure, like a TURP, transurethral resection of the prostate for an enlarged prostate, those men should probably have a culture first, because if they have the asymptomatic bacteriuria and then they have that procedure, that allows free access of the organisms into the bloodstream. The likelihood of your needing an X-ray or a CAT scan or an ultrasound examination, just not appropriate in those people who have run-of-the-mill urinary tract infections. But if there's a thought that you might have a kidney stone or polycystic kidney or something else, then that might be appropriate. People need evaluation if they have a history of urinary tract infections that are associated with red blood cells, and after the treatment there are still red blood cells in the urine and they persist, need some kind of treatment, need some kind of evaluation. Or if you have a history of a urinary tract malignancy, a cancer, or trauma to the urinary tract, or you've had a history of diverticulitis, or maybe a kidney stone, maybe you can't void appropriately, or you've had a history of resistant organism, well, those are the people who need more evaluation. Now, typically, we believe that a urinary tract infection occurs when the bacteria get into the bladder itself, into the cavity of the bladder, and then they attack the bladder cells. And it's the response of the bladder cells to the presence of the bacteria that lead to the symptoms of the infection. So how do the bacteria, the same bacteria, come back again then if we get rid of them? Well, it's interesting that sometimes the bacteria can actually invade into those cells, into the cells lining the bladder. They can form a biofilm and live there for a good long while, months to years. They keep replicating themselves, and as the cells in the bladder shed, the bacteria infect new cells, but it's an asymptomatic infection, sort of much along the lines of what happens with the herpes virus or the wart virus. They persist for a long period of time, and then they can recur. And that's what happens with urinary tract infections when it's the same bacteria, as it is in 50 to 90% of recurrent cases. Now, let's say you have a urinary tract infection. How are we going to handle it? Well, typically with an antibiotic, macrobid or nitrofurantoin, one of the most common that's used. It only works inside the urinary tract and only in the bladder, not in the kidney. You take a pill a day, or a pill twice a day, and you do that for about 5 days. We used to think longer therapies were necessary, but they're not. Or you might take the generic of Bactrim or Septra. We call that trimethoprim sulfamethoxazole. You can take 1 pill a day, or 1 pill twice a day, and you do that for 3 days. That should clear cystitis. Now, sometimes there's resistance, so it might not be appropriate for all women, but it's pretty good first choice. There's another medicine that's being pushed that you only have to take 1 dose. It's called Monuril, and this drug seems to be a little less effective than either the macrobid or the trimethoprim sulfamethoxazole combination. Little less effective, little more costly, but you only need to take 1 dose. Now, half of the women who see their physicians are going to be given a fluoroquinolone, Levaquin or Cipro, but the Food and Drug Administration says, hey, that's kind of inappropriate. We should reserve these drugs the fluoroquinolones, the Cipro and the Levaquin, for women who have pyelonephritis or the invasive disease, because, one, these drugs are important for other kind of infections, so we don't want too much resistance to develop, and they're kind of hard on your tendons and your joints and your nerves. If you do require one of these drugs, if it's Cipro, it's probably about 5 days. If it's Levaquin, it's probably about 3 days. Or less commonly, people take amoxicillin or cephalexin, Keflex, drugs in that family. They work for a significant number of women, but resistance is becoming more common. So we have at least 10% resistance to the fluoroquinolones, the Cipro and the Levaquin, and if you go to a place like Turkey, it's more than 40% resistant. And if you look at Bactrim, now we're up to 20% resistance. So if you go on a vacation, it all depends where you go in the world. Well, when you come back here, you got to tell the doctor, because depending on where you happen to get the infection, it might be due to a resistant organism. Now, if you have pyelonephritis, remember, it could be exactly the same kind of symptoms or could be more severe symptoms. But pyelonephritis needs a longer course of therapy, typically from 7 to 14 days. Same sort of antibiotics, but not the nitrofurantoin and not the Monurel. Well, what are our options for antibiotics? The options are, if you have an infection, you could go to the doctor's office, or if you have recurrent infections, you could call the doctor's office, and as long as you don't have a history of sexually transmitted diseases or symptoms of pyelonephritis, if you have the same sex partner and all, then simple telephone call to the pharmacy might get you the drug. If you have a history of recurrent urinary tract infections, you might want to keep a stash of antibiotics at home, and at the first sign of an infection, then you can begin your own therapy. We call it self-directed therapy, or for those women who have significant number of infections, they might want to take prophylactic therapy. So every week you take a pill, or maybe 2 or 3 times a week you take a pill, or even for some women it has to be on a daily basis. And for those women who have at least 3 or 4 urinary tract infections during the course of a year that seem to be related to sexual activities, well, we can decrease the number of urinary tract infections by around 95%. Simply by taking an antibiotic at the time of sex or immediately after sex. And you could take the nitrofurantoin or the Septra or the Bactrim or just even the trimethoprim by itself. But you have to take it within 2 hours of sexual activities. Now, the problem with taking too many antibiotics is that we're seeing a lot of resistance to the antibiotics. So they don't work as well as they used to work. And antibiotics can cause nausea and upset stomach and headache and rash. And they can cause vaginal yeast infection. They can cause problems because they kill off the supposed good bacteria, so now you can get diarrhea. You can even get Clostridium difficile overgrowth, and that can lead to a horrible type of a diarrhea that in some cases leads to hospitalization and even death. That's why you hear about so many fecal transplants now. It's to treat that Clostridium infection. And then we have the resistance. So because we have so much resistance and because of the history of urinary tract infections, well, some people have come up with the idea, geez, why don't we just treat with an anti-inflammatory, a drug like aspirin or ibuprofen or naproxen? And maybe that will be sufficient, or maybe just an analgesic for the urinary tract. Some drug called pyridium, you can take pyridium with each meal 3 times a day for a couple days. That'll get rid of the dysuria, the pain, and maybe the bladder can take care of itself. It'll stain the urine sort of an orangish red, but at least 1/3 of women who have urinary tract infections are going to spontaneously resolve, so maybe the antibiotics are not really the answer. And there's an increased number of physicians who are starting to treat just symptomatically. And if the symptoms don't go away, or if the urinary tract isn't clear within 3 or 4 days, then maybe consider starting the antibiotic. That's a new school of thought that's increasing in its prominence. What about probiotics? They just don't seem to work. Some people take mannose because if you take mannose, supposedly that chemical is going to interfere with the bacteria and their ability to latch on to the cells in the bladder. Doesn't work. There's methenamine. Doesn't work. Chondroitin sulfate. Doesn't work. The whole idea about cranberries, well, it was thought once upon a time that if you take cranberry juice, that's going to help protect the urinary tract, help protect it, because it's going to make the urine more acidic. Supposedly it'll make hippuric acid, but it really doesn't have a substantial enough concentration to do any good. So then they changed their mind and said, no, it's a different kind of a chemical. It's something called proanthocyanidin. And you can take that as a tablet, or you could take that as a capsule. And if you take 36 to 72 milligrams a day, supposedly, it's going to interact with some of the structure on the bacteria. But study after study shows it doesn't really work. Well, the good news is they're working on a vaccine, and probably within the next several years there's a pretty good chance that there will be at least a partially effective vaccine against urinary tract infections. Well, now we have another issue. And the added problem that we have to now face is that once upon a time, we thought the urine was sterile in most people. Well, just like with the intestine, there are lots of bacteria. If you look at your skin, there are lots of bacteria. If you look in your mouth, there are lots of bacteria. Look on the surface of your eye, lots of bacteria. And so too, normal people have a considerable array of different bacteria that tend to be different from the kind that cause urinary tract infections, but the urine is not sterile. So we have lactobacilli that grow in the vagina. We have the Corynebacterium that grow on the skin. We have certain kinds of staph and actinomyces. And we have even Gardnerella. Now, they don't grow in routine cultures because they require special growth factors. They often grow if there's not oxygen. They're what we call anaerobic organisms. They take a longer period of time to grow, and they've already thrown the culture out in the laboratory long before these sort of organisms will grow. But as we learn more about the urinary tract, we think that some of these organisms might actually be the cause of overactive bladder, possibly interstitial cystitis, probably or possibly incontinence of the urge type or the stress type. So I guess we've gone full circle. Now you should know pretty much everything you need to know about urinary tract infections. Thanks for watching. I'm Dr. Ken Landau.